Let's dive right into this explainer by looking at a fascinating and frankly sobering medical case. Imagine a 12-year-old boy presenting to the clinic. He's got a recent history of streptococcal pharyngitis, just a simple sore throat really. But now he's developed severe shortness of breath, profound fatigue, and chest pain, even while he's just sitting there resting. Tests reveal his cardiac output is dangerously plummeted to below 5 liters per minute. What we are witnessing in this young patient is the ultimate mechanical breakdown of the human body's most vital engine. We're looking at heart failure.
Here's our roadmap for tackling this dense topic today. We're going to cover 1. The anatomy of a broken pump, 2. The body's flawed rescue, 3. Plumbing and structural leaks, 4. The heart's electrical wiring, and finally, 5. Fixing the failing engine.
All right, part 1. Anatomy of a broken pump. First things first, we need to establish exactly what happens when our most critical pump starts to fail. Now, according to the American Heart Association, heart failure isn't just a single disease. It is a complex clinical syndrome. It can actually stem from functional issues outside the heart, like chronic hypertension, or structural abnormalities inside the heart, like damaged valves. But the absolutely crucial takeaway here is this. Whether the ventricle is failing to fill properly or failing to eject properly, the ultimate consequence is a severe decrease in cardiac output. The heart simply cannot meet the metabolic demands of the body. The tissues are quite literally starving for blood.
Now, a really important clinical distinction we make is between the two main types of heart failure. On one side, we've got systolic heart failure. This is the most common type, and it's basically a failure of the left ventricle to eject blood. You'll see this characterized by a noticeably decreased ejection fraction. The three main culprits here are a decrease in the heart's contractility, an increase in afterload, which is the resistance the heart has to pump against, or an increase in preload, the actual volume stretching the heart. On the flip side, we have diastolic heart failure. This is less common. It's primarily a failure of the ventricle to relax and fill up with blood, often because of a decreased diastolic filling time. But interestingly, the actual ejection fraction remains preserved.
You can see how the physical structure of the heart muscle, the myocardium, directly dictates these failures through conditions we call cardiomyopathies. If you look at the dilated cardiomyopathy there on the top right, the left ventricle is completely blown out and enlarged. It totally loses its pumping power and fails to eject blood, which leads right into that systolic failure we just talked about. Contrast that with hypertrophic and restrictive cardiomyopathies. In those cases, the muscle is either thickened or stiffened, which literally restricts the chamber from filling properly, and that directly causes diastolic failure.
Moving on to part 2. The body's flawed rescue. So when the heart's cardiac output drops, the mean arterial blood pressure falls right along with it. The body completely panics and initiates this dramatic, totally counterintuitive rescue mission known as cardiac remodeling. This refers to biological changes in the mass, volume, and shape of the left ventricle as the body desperately tries to keep cardiac output normal. Now, you might logically assume that these built-in survival mechanisms are helpful, right? But are they really? Well, here's the wild part. It is actually a deeply flawed rescue. The body deploys 3 main systems. First, the sympathetic nervous system, or SNS, kicks in to ramp up the heart rate and constrict arterioles. Second, decreased kidney perfusion triggers the RAAS system, producing angiotensin II for massive vasoconstriction and aldosterone for sodium retention. And third, ADH, or antidiuretic hormone, increases water reabsorption. Now sure, these systems temporarily prop up blood pressure, but they pathologically increase preload and afterload. Think about it, they are forcing a damaged, failing engine to work even harder against more resistance with way more fluid volume. It's exactly like a terrible mechanic trying to fix a fragile, leaky pipe by cranking the water pressure up to the absolute maximum. Ultimately, this so-called rescue just creates more stress on the heart and accelerates its destruction.
Let's look at part 3, plumbing and structural leaks.
Having seen that flawed rescue, let's look at the physical blockages that actually cause these mechanical failures in the first place. Ischemic heart disease is fundamentally a plumbing problem. It's driven by atherosclerosis, which builds up like toxic rust inside the coronary pipes. It all starts when LDL cholesterol enters the vessel's intima and becomes oxidized. The body's macrophages show up to clean the mess, they engulf the oxidized LDL and transform into these fatty little things called foam cells. Next, smooth muscle cells migrate over and deposit collagen, which builds up a really dangerous plaque. If that plaque tears, a thrombus can form. And if that thrombus totally blocks the artery, that results in a myocardial infarction, a heart attack. Doctors can actually diagnose this by looking for a very specific serum marker in the blood called troponin I.
But, it's not just the pipes, the structural valves can fail too. Remember our 12-year-old boy from the very beginning with the strep throat? An untreated group A streptococcal infection can actually lead to rheumatic fever, which severely damages the heart valves, and this is incredibly common in developing regions. Whether it's a stiff valve that won't open, which we call stenosis, or a leaky valve that won't close, which is regurgitation, you can actually figure out the resulting heart murmur just by knowing basic normal anatomy. For instance, the aortic valve is supposed to open during systole to let blood out. If it's narrowed and can't open properly, it forces blood through this tiny little space. That creates aortic stenosis, which produces a classic systolic murmur.
Now for part 4, the heart's electrical wiring.
Beyond the plumbing in the valves, the heart is ultimately a machine powered by electricity. It relies on a highly sophisticated electrical conduction system that starts way up at the SA node pacemaker and travels incredibly fast down to the Purkinje fibers to coordinate every single beat. Let's connect the macro view to the micro view here. The systemic ECG tracing shows us the P wave, the QRS complex representing ventricular depolarization, and the T wave. We can map that directly to the exact cellular action potential driving it. Phase 0 is the rapid upstroke caused by a massive influx of sodium. Phase 2 is the plateau phase, which is critically maintained by an influx of calcium. And Phase 3 is repolarization driven by the efflux of potassium. It's this precise, beautiful cellular choreography that registers as those familiar spikes on an ECG monitor.
But here is a really fascinating quirk. The SA node, the actual pacemaker itself, plays by entirely different rules. Unlike the ventricular cells we just talked about, the SA node's action potential completely lacks phases 1 and 2. Instead, it relies uniquely on an influx of calcium for its rapid phase 0 depolarization, not sodium. Plus, it has this slow, continuous phase 4 depolarization. This totally unique, unstable resting potential is exactly the feature that allows the SA node to automatically fire and consistently drive a human heart at a resting rate of around 70 beats per minute.
Finally, part 5, fixing the failing engine.
Okay, so now that we comprehensively understand the structural breakdown, the plumbing blockages, the electrical glitches, and the body's deeply flawed rescue mission, we're ready to open the medical mechanics toolkit. To treat heart failure, we rely on a specific arsenal of drugs. You can remember them with a handy acronym ABCDV. That's ACE inhibitors, ARBs, beta blockers, cardiac glycosides, diuretics, and vasodilators. The absolute main goal of these drugs isn't just to make the patient feel a little bit better. It is to fundamentally reverse the damage. We have to increase the heart's contractility while simultaneously decreasing that punishing preload and afterload that the body's flawed rescue systems have maliciously dialed up.
We can get incredibly precise here by targeting the plumbing system to relieve the pressure on the heart. On one end, we use venodilators like nitroglycerin. By dilating the veins, we pool blood in the venous system, which decreases venous return. This brilliantly drops the preload that is stretching out the heart. On the other end, we use arteriodilators like hydralazine. By dilating the arteries, we decrease total peripheral resistance, effectively dropping the afterload, which makes it dramatically easier for a weakened left ventricle to actually push blood forward.
And to fine-tune the engine even further, we deploy diuretics and glycosides. Loop diuretics like furosemide aggressively drain excess fluid straight out of the body, directly dropping that preload. Potassium-sparing diuretics like spironolactone are amazing because they actually block aldosterone, preventing that toxic cardiac remodeling we discussed earlier. Meanwhile, cardiac glycosides, like the plant-derived drug digoxin, tackle the whole problem from the exact opposite end. They forcefully increase the heart's contractility by inhibiting the cellular sodium-potassium ATPase pump. This leads to a surge of internal calcium that makes the failing heartbeat significantly stronger.
As we wrap up this explainer, we're left with a pretty profound paradox to consider. We literally spent millions of years evolving survival mechanisms like the sympathetic nervous system and RAS just to keep our blood pressure up during emergencies. Yet in heart failure, these very biological safety nets act as an anchor, dragging the failing heart down. It really forces us to realize that the marvel of modern pharmacology, drugs like beta blockers and ACE inhibitors, doesn't just fix a broken pump, it actually saves the heart from the body's own deadly attempts to heal it. It makes you wonder, what other flawed rescues is our biology hiding from us?